All right. Hello, everyone. I trust if you're here, you are a 400 level medical student, and I'm really glad to have you here. So today we'll be discussing on the drugs used in the treatment of hypertension. So actually, this is the very first video of this channel. So I'll be so happy. It would mean a lot for me if you just hit the subscribe button below. It's actually going to mean a lot. So this video is relatively long, so don't get discouraged because it will actually be the best video you've ever seen on drug treatment of hypertension anywhere in the internet. I promise you that. I'm not missing it. It's going to be absolutely worth your time. So let's go. So this is my outline, introduction, goals of treatment, classification, diuretics, sympathopletics, vasodilators, RAS agents. So these are the outlines we are going to be using for this tutorial video. Now, introduction. By way of introduction, we are talking about the drugs used in treatment of hypertension. We can't just go straight up into the classification of these drugs. At least you need to know what hypertension is. Same way goes for your theory exams. If you are writing theory, they tell you to describe the drugs used in treatment of hypertension. You don't just go straight into classifying the drugs. You need to give an introduction. Define hypertension. So you can see hypertension can be defined as persistent increase in blood pressure above 140/90 millimeter mercury, measured on 3 different occasions. So before a diagnosis of hypertension is made, it has to be measured on 3 occasions because a high blood pressure on just one occasion is not enough, because sometimes there's something called a white collar hypertension that patients can develop when they see a doctor. So that in that kind of instance, that cannot classify as hypertension, because once you start a patient on antihypertensives, they take that drug for life. So you have to be careful as a doctor, as a medical student. You're learning. You have to know that you have to be careful when diagnosing hypertension. Although there are some instances where you measure once and you start treatment. We measure once, diagnose hypertensive once, and you start treatment. There are some instances, for example, if the patient comes with or the patient presents with symptoms of complications. So the patient comes with their antihypertensive medication. So that is also some instances. So drugs in the treatment of hypertension, they are called antihypertensives. So this is enough for our introduction. Next, the goals of treatment. So when you are giving antihypertensives, what are you trying to achieve? You get what is the goal of your treatment? What is the whole aim? The whole aim of giving antihypertensives. So for that, you need to know that blood pressure is a function of cardiac output and peripheral resistance. So both cardiac output and peripheral resistance contribute to blood pressure. You should know that in your physiology. So the goal of antihypertensives. So when there's hypertension, there's high blood pressure, it means either or both of cardiac output and peripheral resistance is increased. So the goal of treatment, the goal of giving antihypertensives, the aim of giving antihypertensives is to reduce the cardiac output and or peripheral resistance. So now let's go to the classification. The classification of antihypertensives can be classified into 4. We have the RAS agents, we have the sympathopletics, we have the diuretics, and we have the vasodilators. Now, some books might not use this classification. So actually, this classification, I got it from the baby Katzung. There's this baby Katzung, not the big Katzung, the baby Katzung. So this is the best and most simplified classification I've seen anywhere. So that's why I've used it. So you can follow this, and it's quite explanatory, and you get to understand it. The mnemonic is RSVD, rice and stew, very delicious. Very sweet mnemonic. Rice and stew, very delicious. RAS agents, sympathopletics, diuretics, and vasodilators. Now let's move on. So we'll start with the diuretics. We're not going to follow in that RSVD order. So we are going to start with diuretics. So diuretics is a big topic on its own. Yeah, it's a very, very big topic. It's not actually a big topic, but it's a separate topic on its own. But we are going to look at it briefly under this tutorial video. So diuretics are pharmacological agents that aid in the excretion of salt and water, and they are used in the treatment of hypertension. They are used in treatment of hypertension, though some of them, like carbonic anhydrase inhibitors, is a class of diuretics that is not typically used. It's not used in the treatment of hypertension. So the ones used in the treatment of hypertension are thiazide and loop diuretics. Those are the two major ones that are used in treatment of hypertension. So examples of thiazides are chlorothiazide, hydrochlorothiazide, and benzoflumethiazides. Examples of loop diuretics are furosemide, torsemide, and bumetanide. So generally, thiazide diuretics, they have a longer duration of action than loop diuretics. So loop diuretics, they tend to be used mainly for hypertensive emergencies because of their short duration of action, while thiazides are more fitted for chronic hypertension. Okay, let's move forward. Now we have finished diuretics, we are on to sympathoplegics. So sympathoplegics, they reduce the effect of the sympathetic nervous system as seen on the slide. So from the word plegia, hemiplegia, paraplegia, you get plegia, meaning paralysis. So sympathoplegics paralyze the sympathetic nervous system. You get? So they reduce the effects of the sympathetic nervous system. So classification, they can be classified into 4. Sympathoplegics can be classified into 4. Hope you are following. Centrally acting sympathoplegics, ganglion blockers, postganglionic blockers, and adrenergic blockers. Actually, this should be post-ganglionic nerve terminal blocker. So it actually acts on the nerve terminal, so you can correct this to postganglionic nerve terminal blocker. And then adrenergic blocker. So the mnemonic is CGPA, cumulative grade point average. Simple and short. So this is a brief diagram. This diagram was gotten from the Katzung book, the small Katzung book. So this is for the sympathoplegics. This is a diagram showing the sites of action of the sympathoplegics. So we have the sympathoplegics. So we have we have centrally acting sympathoplegics. We have ganglion blockers sympathoplegics. We have the post sympathetic nerve ending blockers, and then we have the adrenergic blockers, CGPA. So for the centrally acting, they act on the brainstem. The site of action is in the brainstem. So yeah, on the brainstem. So the ganglionic blockers, they act here. The post-sympathetic nerve ending blockers, they act here. And then the adrenergic blockers, they act on the effector sites. Yeah. So you can see this is for C. This is for G. This is for P. And this is for A. So CGPA, cumulative grade point average. Simple and short. You see, pharmacology is not so hard. Okay, next. So now we are going to be looking at the centrally acting sympathoplegics. Now, the centrally acting sympathoplegics, they are alpha-2 selective agonists. These alpha-2 receptors, they are located in the presynaptic neurons of the nucleus of the tractus solitarium of the brainstem. So I told you the act centrally from that previous slide that you saw. So in the brainstem there, that is where we have these NTS neurons. So these alpha 2 receptors are there. So the effect of these receptors, or the effect of these drugs, is that they decrease sympathetic flow, central sympathetic flow. So by decreasing that flow, they decrease cardiac output and peripheral resistance, and they decrease blood pressure. So I come again, alpha 2 receptors, as you can see, located in the presynaptic neurons of the nucleus of the tractus solitarius. Very, very important for MCQ purpose. This very, very important of the brainstem. So they cause decrease in sympathetic outflow. Two major examples that you must know are clonidine and methyldopa, alpha methyldopa. So here we can see the solitary tract nucleus. This is the solitary tract nucleus, located in the brainstem. Okay, so let's move on. So let's talk about clonidine. I told you two major examples of centrally acting sympathoplegics, clonidine and alpha methyldopa. So let's take a little gist about clonidine. Clonidine is an alpha 2 receptor agonist. Of course, it's centrally acting, so it should have good CNS penetration. So that is some of the any drugs that act on the CNS, just a tip for pharmacokinetics. Any drugs that act on the CNS should have good CNS penetration. So, like I said before, it decreases sympathetic outflow. And one major side effect of clonidine is rebound hypertension. So, when giving a patient clonidine, what is rebound hypertension? This phenomenon simply means when the drug is stopped suddenly, the hypertension comes back in full force. So, when giving a patient clonidine, you should be careful. Tell the patient that this patient, you don't need to stop the drug suddenly. Because once it stops suddenly, it comes back with full force. That is rebound hypertension. So that is that for clonidine. Another interesting centrally acting sympathoplegic is methyldopa. So methyldopa is a prodrug. Prodrug meaning it has to be converted to an active stuff, you get, before it works in the body, like proenzymes, like zymogens like zymogens. They need to be converted to their active form before they can act on the receptors. So methyldopa is a typical example of a prodrug converted to methylnorepinephrine in the brain. So when it is being converted to methylnorepinephrine in the brain, it moves to the alpha 2 receptors in the brainstem, NTS, nucleus of the tractus solitarium, in the brainstem. Of course, it has good CNS penetration like clonidine, decreased sympathetic outflow also like clonidine. And very, very, very important, you should know that it can be used for treating hypertension in pregnancy. Very good question for MCQ purpose. So with this, I'll just give you a mnemonic for the drugs in the treatment of hypertension in pregnancy, because it comes out in MCQ. So we have the mnemonic is he likes my neonates. So there are 4 major drugs: hydralazine, labetalol, methyldopa, and nifedipine. I couldn't put that in the slide, but just know drugs used for treating hypertension in pregnancy. Mnemonic: he likes my neonates. He likes my neonates. HLMN. He likes my neonates. Hydralazine is a vasodilator. He likes labetalol, which is an adrenoceptor blocker. He likes my methyldopa that we are seeing here, and nifedipine, which is a calcium channel blocker. We'll check on these drugs later on. So, side effects of methyldopa is hematological immunotoxicity. It means it can cause drug-induced hemolytic anemia. You'll see that more in your hematology. So, evidence as positive Coombs test, that will also be talked about in your hematology. So now we are moving on to the ganglion blockers. So these guys, they block nicotinic receptors at autonomic ganglia. So we saw that picture the other time. Let me go back. So yeah, this is the ganglionic blockers. This is where they work. The G here for ganglionic blockers. So in this place here, we have nicotinic receptors. We have nicotinic receptors. So these ganglionic blockers, they block the nicotinic receptors located in this autonomic ganglia. So that's how they work. So by doing that, they block, or they decrease sympathetic outflow. So let's go back to our slide. Okay, sorry. Yeah, so this is it. So I've already explained it. They block nicotinic receptors at that autonomic ganglia. So because of their severe side effects, they are now considered obsolete. Obsolete, that's not a big word. It means they are no longer used, or they are rarely used, rather. They are rarely used. Example, hexamethonium and trimethophan. You don't really need to know much about this because, like it said there, they are rarely used. So let's move on. Postsympathetic nerve terminal blockers. So these ones, they act on the postsympathetic nerve terminal. The video, they act on the postsympathetic nerve terminals. The picture we saw the postsympathetic nerve terminal in the other picture. I can't be going back to the slide again because of time. So they deplete they have two major actions. They deplete adrenergic nerve terminals of e-stores, or they block the release. So it's either they prevent noradrenaline from being stored in the synapse there, or they prevent the release. So example of drugs that deplete stores is reserpine. Example of drugs that prevent release, guanethidine and guanidrel. That is basically what you need to know. These drugs are not clinically used these days. So all you need to know for now is that example of drugs that block release of norepinephrine from stores, guanethidine and guanidrel. Example of drugs that block nerve terminals of norepinephrine stores, reserpine. This is actually going to be discussed more in ANS pharmacology. Alright, so there'll be a video for that. Video for another day on ANS pharmacology. So we'll look more into this. So the next is adrenoceptor blockers. Still, this is also part of ANS pharmacology. This is another big topic on its own. But for now, we'll look briefly at it. So what are adrenoceptor blockers? As the name implies, they block adrenergic receptors at effector sites. There are different classes of adrenergic blockers. We have the alpha-1 selective blockers, alpha-2 selective blockers. We have beta-1 blockers. But that is going to be talked about under ANS pharmacology. For now, we need to know that those adrenoceptor blockers used in the treatment of hypertension are the alpha-1 selective blockers and the beta blockers. So alpha-1 selective blockers, they block only alpha-1 receptor at effector sites. So these alpha-1 receptors majorly located in the blood vessels. So blocking these receptors reduce peripheral resistance, because these alpha-1 receptors, they are responsible mainly for vasoconstriction. So once these receptors are being blocked, there is less vasoconstriction and there is decreased peripheral resistance, because vasoconstriction leads to peripheral resistance, increased peripheral resistance. Once alpha-1 receptors are blocked, there is decreased vasoconstriction, there is decreased peripheral resistance. Another exciting thing about the alpha-1 blockers is that they relax smooth muscle in the prostate, and so they are useful in the treatment of benign prostatic hyperplasia. Very, very, very useful for MCQs. So you should know these MCQs. This useful in the treatment of benign prostatic hyperplasia. Very, very important for MCQ. Examples are doxazosine, all these are zosins, tamsulosin, prazosin, terazosin, doxazosin. Common side effect is orthostatic hypertension. So we'll move forward to the beta blockers. So they can be beta 1 selective blockers. They can be non-selective beta blockers. These beta blockers, they'll be talked more under ANS pharmacology. So, but for now, let's see what we have here. The beta blockers, they block beta receptors at effector site. Generally, all beta blockers, they block beta receptors at effector sites. The ones used in treatment of hypertension are beta 1 selective blockers and non-selective beta blockers. The beta 2 blockers, they act mainly on the uterus and the lungs, so they are not of concern to us in the treatment of hypertension. The ones that are of concern are beta 1 selective and non-selective beta blockers. Examples are propranolol. Propranolol is a non-selective beta 1 and beta 2 blocker. There are others that, like carvedilol. Carvedilol blocks both alpha receptors and beta receptors. Note that for MCQ. And put something like that here. Carvedilol. So alpha and beta. Same with labetalol, alpha and beta too. So labetalol and carvedilol block alpha and beta receptors, very important for MCQ. And there are another group of beta blockers called, they are beta blockers with intrinsic sympathomimetic ego. They are intrinsic sympathomimetic action. So this means that these drugs, they can behave like sympathomimetics in some instances. You get? So they have the ability to behave like adrenaline. Normally they're supposed to be beta blockers, but sometimes instead of being beta blockers, they can act like adrenaline. So they're partial agonists. So main effect of these drugs is to decrease cardiac output. Main effect of the alpha 1 selective agonist is to decrease what? Peripheral resistance. I hope you are following. Main effect of the beta blockers is to decrease cardiac output. Common side effects: cold hands and feet, drowsiness, fatigue. So that's that. Now we're going to move on to the vasodilators. Don't forget, to have done diuretics, we have done sympathopletics, and now we are on vasodilators. So what are vasodilators? Like the name implies, vasodilators. They dilate blood vessels. This time by acting directly on smooth muscle cells through non-autonomic mechanisms. You get? So they act directly on the cells. They don't act through. They are not like the alpha 1 selective blockers. Those ones, they act through autonomic. They are part of the sympathetic nervous system stuff and the rest of them. But these blood vessels, they act directly. They are direct. They don't act through the adrenergic receptors. So they don't block the calcium channels located in the smooth muscle cells. I know it's going to be no, actually sorry, I got it all mixed up. So just take it the way it is here. They dilate blood vessels by acting directly on smooth muscle cells through non-autonomic mechanisms. So like I said earlier, they don't act on they don't act on receptors. It means any of the actions are not related to the autonomic nervous system. So they are not acting on alpha receptors, they're not acting on beta receptors, they're not acting on ganglia, they're not acting on nerve terminals. I know it's quite hard to grasp, but just try. Okay, so there are different classes of vasodilators. Calcium channel blockers. So I grouped hydralazine and minoxidil together because they are both oral I group nitroprusside and dioxazide together because they are both parenteral. So the calcium channel blockers. Okay, so these guys, they block L-type calcium channels located on the vascular smooth muscles. So there are other type of calcium channels like the T-type calcium channels, which is located in thalamus. That is where ectosuzumide is an anti-epileptic drug. So that drug acts on the T-type calcium channels located in the thalamus, but the calcium channel blockers act on the L-type, very, very important, especially for MCQ, L-type calcium channels located on vascular smooth muscles. So they can be classified into two major groups. We have the non-dihydropyridines and the dihydropyridines. So the non-dihydropyridines are subclassified into two: the benzodiazepines and the phenylalkylamines. The benzodiazepines example is diltiazem. The phenylalkylamines example is verapamil. And you should know that the non-dihydropyridines have more effect on cardiac musculature. You should never forget this. Even when writing your theory, you should put this, and it's always coming out in MCQs too. So the other one is the dihydropyridines. These ones actually kind of more, they are much more used in clinical practice than in the other ones. So most times you hear of nifedipine everywhere. So they can be classified into short-acting, medium-acting, and long-acting. Short-acting nifedipine, clevidipine, medium-acting nicardipine, and long-acting amlodipine. What this means is that if there's hypertensive emergency, somebody just comes to the hospital with blood pressure of 180/200, very high. Or 180/100 rather, 180/100, 180/120, high, and hypertensive emergency. What are you going to give to the patient? You cannot give the patient amlodipine because amlodipine is long-acting. Instead, you can give nifedipine or clevidipine. I think clevidipine is more used in clinical practice for hypertensive emergencies. So they have more effect on vascular smooth muscle. So most of these drugs have a short duration of action. Most of these antihypertensives that have short duration of action, they are used for hypertensive emergencies. Example is labetalol. Example is loop diuretics like furosemide. Example is clevidipine. So you should know that calcium channel blockers, they possess intrinsic diuretic property. So most times they don't need to be used in combination with amlodipine, in combination with diuretics. Side effects include hypotension, headache, constipation, reflex tachycardia. So now we're moving over to hydralazine and minoxidil. So hydralazine, minoxidil, they are both oral. So classify them together because they are both oral. One, hydralazine causes nitric oxide release from endothelial cells, while minoxidil is a potassium channel opener. Hydralazine is indicated for hypertension in pregnancy. Like I said before, the drugs used for hypertension in pregnancy: hydralazine, labetalol, methyldopa, and nifedipine. So hydralazine can be used for hypertension in pregnancy. Side effect: it has a lupus-like effect. Lupus, you will see that more in your pathology where you deal systemic lupus erythematosus. So it's kind of similar to what happens with methyldopa. So it causes a lupus-like effect. It's an immunological thing, like a reaction to the drug, especially at doses above 200 mg per DL. For minoxidil, side effects, hirsutism, because it causes excessive hair growth, so it can be used for treating baldness. So this drug, when giving it to a female, you should be careful. Like I said before, it's a potassium channel opener. It's a prodrug. Another prodrug we saw before was methyldopa, converted to methylnorepinephrine. This one can be converted to minoxidil sulfate, a potassium channel opener. They are both oral, have relatively long duration of action, so they can be used for treating chronic hypertension. They are not used for hypertensive emergencies. So next on our list for the vasodilators is nitroprusside and diazoxide. Both of them parenteral, both of them short duration of action, both of them can be used for hypertensive emergencies. So this one, nitroprusside causes nitric oxide release from the drug molecule. You see, both nitroprusside and hydralazine cause nitric oxide release. Both hydralazine and nitroprusside cause nitric oxide release. But the difference between the both of them is that nitroprusside causes nitric oxide release from the drug molecule, but hydralazine causes nitric oxide release from endothelial cells. So this is for treating hypertensive emergency because, of course, short duration of action, parenteral, short duration of action, hypertensive emergencies. Side effects: thiocyanate poisoning, very, very important for MCQ. So diazoxide, also parenteral, like minoxidil, it causes opening of potassium channels. Also for treating hypertensive emergencies, is used to treat hypoglycemia good caused by insulinoma. Side effects: hyperglycemia. So that's that for the vasodilators. Now we are moving to the renin angiotensin aldosterone agents. This is a big one, popularly asked in theories, comes out in MCQs. In fact, this to me is the favorite for lecturers when it comes to drugs in treatment of hypertension. Popularly asked, especially the angiotensin converting enzyme inhibitors. So renin angiotensin aldosterone agents, they inhibit the RAS pathway. Of course, you should remember the RAS pathway in your physiology. So I've got a diagram here. So from angiotensinogen to angiotensin 1, angiotensinogen converted to angiotensin 1 by renin, angiotensin 1 to angiotensin 2 by angiotensin converting enzyme. So angiotensin 2 does all the work. Angiotensin 2 does all the work, does all the vasoconstriction. It also stimulates the release of aldosterone, all the sympathetic effects, increasing blood pressure. Angiotensin 2 is the mastermind behind everything. So this is the RAS pathway here. This is the RAS pathway. Just a brief, very, very brief description of the RAS pathway. This physiology actually. So classification of the drugs. The RAS agents can be classified into 3: the angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, and the renin inhibitors. Okay, so let's look at each one of them. First off, we'll be looking at the angiotensin converting enzyme inhibitors. These ones are the most popular group of drugs under the RAS agents, and they are so popularly asked in theories and MCQs. I don't know why lecturers love them, but popularly asked, and they are popularly used too in clinical practice. You have just like lisinopril, you have just like captopril, you have drugs like enalapril. So angiotensin converting enzyme inhibitors, they lower blood pressure by decreasing peripheral vascular resistance without reflexly increasing cardiac output. The mechanism of action, they inhibit angiotensin converting enzyme. For MCQ purpose, you should know that angiotensin converting enzyme can also be called peptidase and kinase 2. So it can either be called peptidyl dipeptidase, or actually it should be peptidyl dipeptidase or kinase 2. So sometimes you see in MCQs, which of the following drugs inhibits kinase 2? And they'll just bring lisinopril, bring nifedipine, I've never heard of kinase 2 before. Like, are you serious? So you should know now, angiotensin converting enzyme inhibits angiotensin converting enzyme inhibitors inhibit angiotensin converting enzyme, which can also be called peptidase or kinase 2. So what is the function of angiotensin converting enzyme? As you have seen our RAS pathway, it converts angiotensin 1 to angiotensin 2. But one thing we didn't see in that RAS pathway was that angiotensin converting enzyme also breaks down bradykinin. You get? So by inhibiting angiotensin converting enzyme, it means that angiotensin 2 is going down while bradykinin is coming up. So this is up, so this is up, and this is down. And as we know, bradykinin is a potent vasodilator. Angiotensin 2 a potent vasoconstrictor, and bradykinin a potent vasodilator. So angiotensin converting enzyme converts angiotensin 1 to angiotensin 2 and breaks down bradykinin. You get? So angiotensin converting enzyme inhibitors inhibit angiotensin converting enzyme, meaning there's going to be less angiotensin 2 and more bradykinin. So there's less vasoconstriction and more vasodilation, hence decreasing peripheral vascular resistance. So let's move on. Side effects. So sorry, I excluded mistakenly or forgot to put in the examples of drugs for the angiotensin converting enzyme, and this is one example here, captopril. Another example is lisinopril, L-I-S-I-N-O-P-R-I-L. I come again, L-I-S-I-N-O-P-R-I-L. So captopril, there's lisinopril, there's enalapril. So, and the name of the drug, of one of the drugs, captopril, can be used in forming a mnemonic for the side effect. So the side effect mnemonic is captopril, as you can see, and dry cough. Yeah, I forgot to tell you something about bradykinin. So let's go back a little. Good. So there's something very special about bradykinin as it relates to dry cough. So bradykinin here has a role to play in stimulating the cough reflex. So while angiotensin 2 is decreasing and bradykinin is decreasing, there's going to be, of course, decreased vasoconstriction, increase in vasodilation, of course, decreasing peripheral vascular resistance, and because of the bradykinin effect, there's going to be stimulation of the cough reflex, and that is why patients taking angiotensin converting enzyme tend to have dry cough. Very, very important side effect you must know for patients on angiotensin converting enzyme. Dry cough, very, very important. All right, and that is caused because of bradykinin. So most of the times when these patients are coming down with dry cough, they switch over to give them angiotensin receptor blockers. So we'll talk about that in the next slide. So another side effect, angioedema, because of reaction to the drug. There's postural hypertension, another very, very important. It's called the first dose effect, another important side effect. So most of the time, once these patients take these angiotensin converting enzyme, they tend to feel dizzy because of postural hypertension. So teratogenicity, the O, so I missed that out. So there's proteinuria, renal disturbance, indomethacin toxicity. Indomethacin is an NSAID, and L is leukopenia. Okay, so you can see that again. So move on now to the angiotensin 2 receptor blockers. So these guys, they don't block the angiotensin converting enzyme. This time they wait for angiotensin converting enzyme to do the work. Come on, you can do your work. Say your work is to convert angiotensin 1 to angiotensin 2. Fine, no problem. So while angiotensin 2 is coming to the receptors, like yes, they are coming to bind to the receptor and cause vasoconstriction. The angiotensin 2 receptor blockers like the valsartan, the irbesartan, and the losartan, they're like, hey, hold up, guy, hold up, you can't work here. We don't do that here. So that's what they do. So they block angiotensin 2 receptors at blood vessels. Because of this, angiotensin 2 cannot work, no matter the amount of angiotensin 2 in the blood vessels. So it can't work, or rather the effect is decreased, very so much decreased. You get? So because of that, there's not decreased peripheral vascular resistance, because of course angiotensin 2 is not functioning again the way it should be, and so there's decreased vasoconstriction, and of course vasodilation is now increased, so there will be decreased peripheral vascular resistance. So these drugs don't cause cough. Why don't they cause cough? Because they don't act on angiotensin converting enzyme. So bradykinin is still broken down. So as far as bradykinin is broken down, the cough reflex is not really affected. It's still normal, still under the physiological control, so it's not really affected. So they don't. So most of the time when you see patients complaining of cough from lisinopril or captopril, they are moved over to irbesartan or losartan. So renin inhibitors, there really isn't much to talk about the renin inhibitors, except that it inhibits renin secretion. So renin converts angiotensinogen to angiotensin 1, the RAS pathway. A good example is aliskiren. So with this, we've come to the end of drugs used in treatment of hypertension. I really hope it was worth it. In fact, I know it was worth your time. So you could go over this video over and over again,